Hello everyone, I am Dr. Sundep Sharma and I welcome you to this discussion where I am going to tackle, based upon a case scenario, a topic which always creates problems in understanding, that is hemodynamically significant PDA. The discussion is based upon a variety of textbooks. It includes the key points mentioned in the new Nelson 22nd edition as well as the AIMS protocols which have been released this year. I will try to give you useful information which you can understand. Yes, there will be technicalities we will be using, but I will try to keep it as simple as possible and only the things which you need for understanding the disease, understanding the topic, and marking the answer if you get it in the exam. So let us start with the case scenario first of all. So the case scenario goes something like this. There is a preterm neonate, 29 week 5 days, who was delivered by lower segment cesarean section. The indication was maternal toxemia of pregnancy. So the baby was delivered because of maternal indication. The baby was given prophylactic surfactant because it was a preterm child, so it was decided to give surfactant therapy and managed in newborn ICU. He was on IV fluids initially and hemodynamically stable. Normally, we plan a echo after 24 hours, usually around 36 hours or so. But in this child, obviously, because he was in ICU and you also have to look at surfactant has been given. So, and the logistics are also there. So, on day 3, an echo was performed. No harm in that, no problem here. The echo was performed in view of some distress present and bounding pulses present in the patient. So, the child was otherwise stable, but some distress was there and bounding pulses was present. And it is a preterm child, remember. So, echo report revealed an open large PDA with a transductal diameter of 2 millimeters. It is a significantly enlarged ductus arteriosus, and there was a predominant left to right shunt. Remember the funda that if there is a bidirectional shunt in the first 72 hours or so, it does not indicate a significant PDA. Yes, it can or it may remain patent for a long duration, but it is not significant enough. But in case there is a significant pulsatile left to right shunt, that will indicate a likely important significant PDA. And LA to AO ratio was found to be 1.6. We will talk about it in some time. So this is how the report will actually come to you when you are reading a report in a file, in a case scenario, when you are actually seeing a patient. And there were no other structural deformities. He was conservatively managed initially with a repeat echo done 2 days later, showing persistence of the defect with clinical deterioration. Now the important point is child has clinically deteriorated. This is a very, very important point in the form of persistent tachycardia. So what are we dealing with? We are dealing with the PDA. First thing, does the child have hemodynamically significant PDA or not? So the question arises, how do you define, if you get this case scenario, how do you define it? And secondly, would you consider pharmacotherapy or surgical ligation, or do you think that only observation should be fine and conservative management alone you should give without doing any pharmacotherapy or surgical therapy in the patient? The answer to these questions we will discuss in the end of the topic. Let us delve into the topic discussion. Let us try to understand PDA in preterm newborns. So first of all, what is the incidence of PDA? Incidence varies according to the gestational age. So lower the gestational age, more preterm the child is, higher is the risk of PDA. In fact, there is a condition known as term PDA, but we now know that majority of preterm children will have some degree of delayed closure of the ductus arteriosus. It is not always required to be treated, but yes, remember that PDA is predominantly a disease of preterm children. About 15 to 40% of very low birth weight infants are found to have a PDA. And incidence of 70 to 80% is seen in these very low birth weight newborns, right? So incidence is 70 to 80%. So very low birth weight means birth weight less than 1.5 kg. About 75% average will have a PDA. Now, whether it will be significant or not, we will see in some time. And what are the risk factors which lead to the abnormal opening of ductus arteriosus? It does not close. First of all, as I told you, preterm child. So preterm baby, low gestational age. You can write in bracket, low gestational age is one of the risk factors. Secondly, in case the baby is having any degree of hypoxia or acidosis. Hypoxia or acidosis. Thirdly, in case there has been an inadvertent use of IV fluids bracket boluses or high normal maintenance value. In case it has a tendency to produce a degree of volume overload, and that can cause delayed closure of the ductus arteriosus in some of the patients. In fact, sometimes physiological closure has happened. It can open up also in case repeated fluid boluses are given to the patient. Apart from that, in case there is a syndrome associated with patent ductus arteriosus, for example, there is a thing called as congenital rubella syndrome. So the chances of PDA being there will be high. And then in case there is excess circulating prostaglandin levels or prostaglandins in the circulation in the newborn due to any reason, that will also does not allow the ductus arteriosus to close. So these are the important risk factors. There is a huge list, but these are the important ones which I have collected from multiple sources at one place.